honor to introduce our closing plenary. Some of you know her from her television show on TLC. Many of us know her as an experienced educator and a dedicated clinician. This year's closing plenary speaker is Dr. Jennifer Arnold. Dr. Arnold is an assistant professor in the Department of Pediatrics, section of Neonatology at Baylor College of Medicine. She's the medical director for simulation at Texas Children's Hospital. In the role, she implements the use of simulation-based education, research, and patient safety priorities. She was trained in simulation and resuscitative medicine at the University of Pittsburgh, hail to Pitt, at the Weiser Center and the Saffir Center for Resuscitative Medicine, where she was an NIH postdoctoral scholar. She received her medical degree from Johns Hopkins University, then completed her pediatric residency and neonatal perinatal fellowship at the University of Pittsburgh Medical Center. Dr. Arnold's simulation education and research focuses on high-risk training for all clinicians in a large pediatric and obstetrical medical center. She also has received the Ray E. Helfer Award for Innovation in Medical Education from the Academic Pediatric Association for her research in simulation-based education. Ladies and gentlemen, Dr. Jennifer Arnold.
Well, I should give you a hug. Thank you. I'm supposed to go the other way, but yeah, thank you. Hello, everyone. Can you hear me? All right. Excellent. Thank you so much for that really wonderful introduction. Most importantly, thank you to all of my friends and colleagues, those that I do know so well, that I've known for a long time, like Tom from Pittsburgh, my Pittsburgh alma mater, and the Society for having me here today, because it's quite an honor to be amongst so many experts and even, colleagues that have been doing simulation, whether it be for a couple of weeks or many, many years. There's a lot that I am learning from each of you this trip and every time I come to this meeting. So thank you for having me as the closing note. All right, well, I'm going to try and not put everyone to sleep and also try and keep on time because I tend to talk a lot. Quickly, our disclosures, my disclosure is I do speaking for Cord Blood Registry, non-simulation related. But I have one other additional disclosure I should make. I have something called Chemo brain. So many of you, you're supposed to laugh a little. Actually, it's Brian, because I have chemo brain, Brian. Yes, I have chemo brain. I don't know what excuse everybody else has out there. But I thought this was cute to start off with, hopefully to get everyone energized, because many of you might know that I've been recently diagnosed with cancer and now am doing very well on the road to recovery. But I'm not sure that all my synapses are working yet, so thank you. So bear with me, no pun intended, as I try and walk you through my talk. But even though my synapses may not work so well at the current moment, I'm hoping that all of your neuronal pathways after this week are really taking in, making new connections, as the theme of the conference is, with all that you've learned. There is so much to learn at this conference, and I'm hoping in my talk today that I can kind of bring it all together, help those neurons to kind of make new pathways, make new connections, and you can apply what you've learned into your simulation practice when you go home. So, before we get started, I'd like to take a moment to have each of you to make a new connection. So if you could look in the room near you, without having to get up from your chair, hopefully, someone around you, behind you, next to you that you have never met before, or at least don't know well. Share your name, where you're from, and what your interest is in healthcare simulation. So take just a minute to do that. Okay, are we getting near the end? Everybody at least know a name and an interest, most importantly. I'm going to ask everyone to take their seat now. What's that? I know, everyone, this is good. Good networking is happening. Okay, everyone, please take your seats. I don't whistle very well. I could bang on my mic. Okay, all right, great. So I'm hoping there's been some good connections happening because you're going to use that connection as we go through the talk, okay? All right, thank you for doing that. All right, so what are my objectives today? First, I just want to review some of the leading causes of healthcare errors. The topic of the talk is, to err is human and to simulate divine, because I truly believe that. And then we're going to look at how healthcare simulation can be utilized to hopefully decrease those errors that we make as humans. And lastly, list some methods for improving healthcare simulation-based activities for whatever purpose you do in your everyday life, whether it be educational, patient safety, advocacy, research, or competency and assessment. So, why are we all here today? Well, I think I'm speaking on behalf of most individuals in this room that we're here to improve healthcare education, delivery systems, and ultimately to change the way our patient care outcomes are for the better and to save lives, right? That's why we're here. So let's keep that in mind as we go through this information. So what are some of the errors and what's some of the data that we have out there on our healthcare system? And this is all from the US. I apologize for our international colleagues out there. This is US data, but I imagine it's probably not all that much different in many other areas of the globe. We spend about $24 billion every year in this country on medical errors, and approximately 1.5 billion of those are surgical errors. About 2 million unnecessary central line-associated infections happen every year, and according to the IOM, Institute of Medicine, 98,000, or even in the more recent, maybe even more, lives are lost every year due to medical errors. In my role at pediatrics, I'm a neonatologist. About 4,500 of those lives lost are pediatric patients, and depending on which source you look at, medical errors are about the 5th leading cause of death in the US. So that, to me, is some pretty vital statistics that says this is important. Decreasing errors is important. And some things that we already know, and many of you out there already know this, that in aviation, up until probably the 1980s, we had a higher rate of near misses or major incidents and accidents, and the leading cause of those incidents were human error, deficiencies in teamwork, communication, and leadership. And the aviation industry developed something called crew resource management training that made them a much safer and more reliable industry. Similarly, in healthcare, unfortunately, our healthcare crises are more frequent. And just like aviation, however, because, again, we're human, 70% of our mistakes in healthcare are due to similar deficiencies, teamwork, communication, and safety culture. And one of the things that much of simulation experts out there are trying to do is to improve those errors, decrease them with something called crisis resource management training. So not only do we have a high rate of error, at least I would think it's unacceptable to have in such an important field, but our patients are getting more complex. In fact, all of healthcare is getting more complex. They're not only more critically ill, there's so much more knowledge that's being, that's coming out on a daily basis. This is just a little graph you see up here of the exponential increase in medical journal articles. So it's really hard for us as clinicians and as a healthcare system to keep up, both for training purposes, in addition to how we practice, how systems operate, and how we can absorb and assimilate all that information to try and provide the best care. So I kind of argue that the reality is that our healthcare is complexity, growing complexity in patients and in our knowledge and technology has exceeded our individual capabilities as healthcare providers. And much along the lines of what you heard from Dr. Betsy Hunt, healthcare is now in need of more pit crews rather than cowboys. I'm from the great state of Texas, lots of cowboys out there. And we have a lot of cowboy nurses, doctors, respiratory therapists, and there's a certain importance for that, right? Not all of cowboy medicine is bad, but now in this state and age where medicine is so complex, we also need to function better as a team. There is one cowboy I'd like to make reference to because I think if it wasn't for the cowboys of our history, in healthcare, we wouldn't be where we are today. We wouldn't have all that great knowledge that we have to figure out how to utilize the best we can. And that is Dr. Peter Saffir, who, as you know, I trained at the Saffir Center, and he's one of my role models. And if you can imagine today an anesthesiologist being able to paralyze but maybe not sedate a resident to show how mouth-to-mouth works, wouldn't work so well today, right? I don't know, maybe it is happening out there, but I probably not recommend it. But if it wasn't for Cowboy medicine, we may not have the CPR that we have today. And so I'd just like to show a pretty cool video of Dr. Saffir in his work.
He is being ventilated by mouth-to-mouth breathing. The pneumograph tubings over his chest measure the volumes of air moved,
so
as indicated by the arrow in the corner.
Giving
the inflations
nice,
of 1,000 to 2,000 cc's of air are possible for the following reasons. First, the operator produces an open air passage by supporting head and jaw.
And then he
can
showed
determine the adequacy
the importance
of
of good
ventilation
positioning.
by watching the chest movement,
the sniffing
by
position.
feeling the inflation, and by hearing exhalation.
Not so
Second,
good.
inflation pressures are adequate and can be adapted to the...
He put him back in the right position. Thank goodness. So this is a really great film from my mentor, Dr. Pat Kohanic from University of Pittsburgh and the Saffir Center. And I think it's just good to remember where we come from and that the cowboys in medicine are important, but we also now need to transition into effective healthcare teams. And as Dr. Hunt showed yesterday, it really is vital that we practice and we learn how to work together because our healthcare systems are so complex. And this is just an example I'm going to show you in about 11 seconds how quickly a pit crew can completely overhaul a car in the middle of a race. And as Dr. Hunt mentioned yesterday, they're able to do this because they practice as much as they do. This won't take very long. Each person has a specialized role. They have practiced their role over and over and over again. They're changing tires. They're changing steering wheels sometimes, fueling up, fixing any issues, and like that, the car's back in the race. So, pretty incredible. And I think the hospital sometimes feels a lot like the pit. It's very complex. When I go into a code or I go into a high-risk situation, I'm working with a ton of people, and I may or may not know them. I may have never run a code with them before. I may not know what their skills are, if they've ever practiced their skills. Yet we're all trying to reach the same goal. And we all have come to the table with our education and training. We may have trained in silos, right? So I went to medical school as a physician. My nurse went to nursing school. My respiratory therapist went to respiratory therapy school. But have we ever practiced together? And so maybe not. And so I think that the ability to practice together is vital, and that's where simulation comes in. We don't have an opportunity to practice as much as we should. And I'm going to show you this video of a neonatal resuscitation to sort of exhibit what that lack of practice can mean. It's, for those of you who are neonatologists, you will probably be slightly surprised to see some of the functions that happen with NRP, and I can explain for those of you who are not neonatologists.
Can we stop compressions? I want to hear.
So this is in the middle of a code. Baby was just born. Is it possible to make the volume up?
Oh, I only see it on one side. What? Only see the
because they're working.
See the tools rising on one side. Yeah, it's only on the right side.
They're putting in an umbilical line, a central line, trying to perform chest compressions and ventilations in a coordinated fashion while they're doing this.
We need more help in here. I know. I need more help. We need more help? We need more help.
About 10 minutes in, they've identified they need more help.
Is someone turning up Epi?
Either we need a nurse, we need a practitioner, we need a fellow.
Okay.
Okay, how many of you have ever seen something like that happen in a real resuscitation? It's scary, right? And, you know, there are many things to talk about in that debriefing, both technical, behavioral. and maybe some cognitive. But what strikes the most to me is that because that team missed a very important CRM skill, calling for help early, that led them to not be able to do their effective chest compressions to ventilations because they didn't have enough hands on deck to keep following their algorithm. So I guess what I'm trying to say is we now need to move beyond the book knowledge that we have, the technical knowledge that we have, and really work on how we work together as a team and those behavioral skills that are so hard to teach. So again, we need to make connections with each other, with our knowledge, with our technical skills, and how we communicate. We need to coordinate our efforts better. We need to standardize our practice, and we need to use good teamwork. And that can be a challenge, even though we all know this. Every one of you in this room I know knows that. It's still hard. So what I would like to argue, and the purpose of this talk, is that I believe healthcare simulation can make a difference. It can be the change agent for that. And I'm hoping that's why each of you are here. And in our program, one of the things we like to do, we like to think about our simulation-based efforts in terms of what is the purpose of that effort. Ultimately, they're all done to save lives, right, and improve care, quality, patient safety. But there are different formats that we may do it. We may do it in an educational format. We may do something a little bit different that's really focused on a particular quality or patient safety initiative. We might be doing something that's simulation-based, but is really for advocacy, raising awareness, making a difference in the world of healthcare by letting people know how important simulation is. Could be a research project, or maybe a new technology development that we have to make because we want to have the right mannequin for the training need. Or it could be a competency and assessment experience where we're bringing folks in, clinicians in, to really see, are they able to do what we would expect them to do? And so whenever we're defining one of our simulation endeavors, we try and say, okay, what is the primary purpose? And does it fit into one of these categories? So I'm going to go into each of these categories in a little more detail. Arm 1, we call them the arms of simulation in our program. Education. Right? This is the cornerstone of what we do. This is where simulation really gets its big bang for its buck. These are some basic requirements, and you guys likely all know this, for good education-based simulation activities. We all want a safe learning environment so that people can make mistakes and we can learn from them. Good scenario design, effective debriefings, and whether that's the traditional debriefing or, there's a lot of research right now with RCDP, rapid cycle, whatever the debriefing mode, that's where the learning occurs. We also need to monitor our appropriate learning outcomes. So we need to see, is it making a real difference? And just to connect to Dr. Hunt's lecture yesterday, we need to really be looking at the right outcomes in education to see if, even though we may feel good after an encounter, did our learners really learn something? And then last but not least, we need to connect with our clinicians' clinical work and world. If that doesn't happen, learning's probably not going to happen. Because as adult learners, we learn best when things relate to our job and our actual prior experiences. If it doesn't connect with us, either something we've known before or can relate to, or to something I know I need to know, it's going to be hard to remember. And as adults, we like to learn at our own pace. We like to apply things quickly. We're motivated to learn from internal factors. And we like that immediate feedback, and that's what makes simulation so great. So you may all know this. I'm a new mom, and as I've been a simulation educator for quite a while, I knew all this adult learning stuff, and I thought, yeah, that makes sense. I'm an adult learner myself. But I actually think it kind of overlaps with how children learn, and I'm going to give you an example. Children actually learn through connections, just like us as adults. When I have a new experience, I have a frame that I come to it from. It has to relate to something that I know so that I can expand upon my current knowledge, and then it has to also be applicable. And that same type of thing happens for children, and I can tell you because I've seen it in my own son. Children learn when they can connect whatever they're trying to learn either with themselves or their own experience, when they can connect with other learning experiences they've had, or when they can connect with the world around them that they know, and when they're motivated to learn. So what do I mean by motivated? Well, my son loves cookies. So that's a very blurry picture of my son, but that is my son, Will, recently adopted from China, and he absolutely loves cookies. And I'm going to tell you, he hasn't quite mastered the phrase of how to ask for a cookie, but he loves them. And he calls them dedicts. Don't ask me why. He calls them dedicts. I have not a clue yet to this day where that comes from. It's not Mandarin, but it's what he calls a cookie. And so he'll just yell to Mommy after dinner, "Dedic, dedic, dedic," and point to the table. "I want a cookie after dinner." Well, we struggled, both my husband and I, for a long time to try and get him to say, I want a cookie. Even if he doesn't say the A, we'd be happy. We want a sentence as he's trying to learn English. Not a single sentence. Well, we talked to our speech therapist, and she said, you know what, why don't you try something? Try something that he knows, that he's already connected to. She said, does he know what his eyes are when you say I? I said, yeah, I say I. He points to his eyes, and he can say I. She said, try I, want, some sign language, and then get him to say cookie. And she was absolutely right. I sat there with my son for about 5 minutes, and before I knew it, he was saying a full sentence, I want cookie. And it was all because I related the terms that I was trying to get him to say to something he already knew. Now, granted, the meaning was completely different. This I and I is a little different, but it worked. And now he says, I want a cookie pretty darn regularly. I'm going to see if you can see. Pretty darn, not perfect. Will that work here? Might be a little hard to hear.
Try.
Now he's pointing. Now he's want.
What's that?
What?
Want?
Yeah.
Aya.
Cookie.
And then we bring it all together after a little more practice. That was us learning.
What do you say?
What? Didik.
What's a didik?
Cookie.
Cookie. All right. Enjoy your cookies, guys.
And there are the
Yum,
two of them
yum.
enjoying their cookies after much hard work. His poor sister had to wait on him for a long time. So truthfully, I believe simulation is divine because it helps us make connections. It's realistic. It puts us in the environment that we're connected to, that we already know as healthcare providers, and it helps us expand upon that knowledge so that we can improve the good care that we already give. And these are just some of the adult learning principles that I think correlate nicely with simulation, which I've kind of already gone through, so I'm going to skip for the purposes of time. So what I'm now going to do is ask each of you to become a divine simulation educator, right? Education is the cornerstone of what we do as healthcare simulationists. And I'd like you to look at those of you at the end of your aisles. There should be a pile of paper. If you could grab that pile of paper and pass it down so that everyone on your aisle gets a piece of paper, right now would be a good time for that. If you have your own paper, you're welcome to use it. Just kind of pass it around. And looking at these sort of different examples of the different components of best practice simulation education, okay, and they're just up on the board. I don't need to read them all for you because you all already know them. Good education principles, good scenario design, effective debriefing, outcome measures, instructor development, innovation, evidence-based practice. These are all some of the facets, and I know there are many more, of good simulation, but these are some of the crucial ones. I would like each of you to write down one thing on that piece of paper, okay, that you can do over the next year to improve your educational simulation efforts, and then how you might evaluate that change, okay? So if you could just write down, this is learning objective time. One objective that you might have for yourself as a simulation educator, knowing, where your strengths and your weaknesses are. What's one thing that you can either do for yourself or you would like to do to make yourself a better educator? Maybe it's going to a conference. Maybe it's reviewing some best practice, whatever that is, getting some feedback from a colleague on your debriefing skills, okay? And then maybe it's some type of outcome that you're going to try to measure how effective that was. Everybody thinking? All right. Anyone? I'll give you guys another 10 seconds. Hang on to that thought. You'll have some more time to come back to it. Because I'm going to go into arm number 2, quality patient safety. So we have to have sound education principles when we run simulation efforts, but I also believe that much of what we do in healthcare should be focused on quality and patient safety needs. And really, when I think about how in our program we look at a quality and safety need, if either an administrator comes to us with a need or one of our faculty comes to us with a need in their department, or we identify a need, there's 3 different ways that we think about using simulation for the purpose of improving quality and safety. It could be just as an educational strategy for training, improving and maintaining provider care so that as providers we do the right thing and we have good outcomes. It also could be a method for discovering inefficiencies and latent safety threats in our healthcare environments. And that's something that I'm going to talk a little bit more detail about because we've had a lot of opportunity to do in our institution and is a relatively new facet of healthcare simulation. It also could be a method to test or evaluate a new solution or a new practice or a new procedure before you roll it out on patients. Why? Because it's safe, right? We can practice anything we want in simulation and never hurt a patient. So I believe simulation is a great opportunity for these purposes. This is just some background, some literature. So for the academians out there, I want to make sure I share some good, really critical studies that have been shown to how simulation as an educational tool can improve patient care outcomes in quality and safety. Things such as improvement in operating room performance, decreased rates of CLABSI from the CHOP group, improved depth of chest compressions. So these are all really important things, right, from a technical skill perspective or a communication skill. Additionally, when you're looking at teamwork, team-based emergency training, there is some literature that showed teams that practice in simulation can improve the way they perform in the real clinical environment. But I think this world is very open, and we have a lot more to do to look at these T2 and T3 outcomes. How do we do it, though? Okay, so you're in your institution, you're like, I want to make a difference, I want to improve quality and patient safety. Well, these are just some examples of some areas that you can look at. You need the data. You need to connect with the data in your institution. And whether that be CPR data, code data, your institutional dashboards, even satisfaction survey results, your culture of safety surveys, whether it be HRQ or the SAQ, all of those things are really great tools for you to look at. In addition to, of course, polling your administrators, your quality and safety leaders, and the frontline clinicians. Because if anyone knows where the deficiencies are, it's likely your frontline clinicians. But these are hard data that you can look at. And then once you develop, with your innovative simulation mindedness, a project to try and improve that, you want to look at the outcomes. And you can do that in a strict research type environment with an RCT, if that's possible, or other types of outcomes. But particularly with patient safety, there's also the whole area of quality research methodology, PDSA cycles. You can look at control charts and see change quickly. Particularly when you're focused on a patient safety need, you want that change to happen quickly, and you want to measure it quickly and look at the outcomes quickly. So this is a whole area that I think is so valuable for healthcare simulation today. So I'm going to give you an example of, yes, I'm now from Texas. I'm learning to think like a Texan, and this is how Texans think. The world, or the United States of America looks, I should say. Probably if I had the globe, it'd be very similar. But I love Texas now, but we are very proud of our state. And I, come from, I don't know if my pointer will work, but basically on the East Coast here, Houston, Texas. And in our institution at Texas Children's, we've had a rapid growth of new buildings in exponential form, very Texas form. In Texas, everything is big, and we're doing it big. And so because of all the new hospitals that have been popping up since I've been there, we've had just a great opportunity to use simulation for a patient safety need, not necessarily just for training, but to evaluate our new healthcare systems before they open for safety issues. And so that's what I just want to share a little bit about. So we opened about 2 years after I got there, maybe, a West Campus, which is a community-based pediatric hospital. We got an opportunity to get our feet wet at testing using simulation then. And then they decided to take it one step further and build a whole new department, add on obstetrics and gynecology with a women's hospital, which included outpatient, inpatient care, gynecology and obstetrics primarily, and neonatal care. So I got to have a whole nother unit to work on. They didn't close our old one, they just opened another one across the street. So growing, as many things do in Texas, this was a great opportunity for us to really look at those new systems that were going to be pretty different from what we were used to. For number one, obstetrics. Our hospital had no prior experience taking on obstetrics and gynecology. Number two, neonatology. Well, we had been used to working in open bay formats, and we're going to private single rooms. Big stress for many neonatologists that are having this transition. In addition for that, for the children's hospital, although we ran a fully running very large pediatric hospital, this was going to be a little different. This is one where there wasn't going to be an intensive care unit. The code team wasn't going to be comprised of ICU docs. It was going to be comprised of hospitalists. So there were a lot of changes and high-risk points that we knew our administrators were worried about. And so in many discussions, we said, okay, what is going to keep you up at night? What are you worried about? And can we sim it and figure out if what we intended to work, our new processes and procedures for handling those crises, were really going to work? And so I do believe simulation is a powerful tool for this. So we developed a project where we had a series of steps to take on testing basically 2 new hospitals in multiple phases. First, we needed to know who our stakeholders were and their roles. That was pretty big. A lot of people involved: architects, operational leaders, medical leaders, frontline clinicians, administrators. Then we needed to know what were those high-risk points that we were going to sim, because we couldn't sim it all. I could run simulations, I could still be running simulations to test those hospital areas with every possible scenario, but we decided to try and figure out what were the priorities. And then you have to identify the areas and the high-risk cases and look at tools that are going to measure your training. So there wasn't a lot of literature on this, so we really didn't know how we were going to identify and categorize these types of outcomes that we found. So we developed some tools for this, and then we did the testing. And I say testing because it wasn't a training, and it wasn't about the providers that were going to go through these scenarios, and that was really important to let them know. This was about testing our system, a new system that none of us have ever worked in. So how do we prioritize those threats? We made connections with data. Again, making connections. Look at your data. We reviewed whatever literature there was on those high-risk areas. For example, obstetrics and gynecology. We did poll our content experts, but we also looked at some data in the literature. But we also looked at our current patient safety and quality data in our existing hospitals for other common themes. And we also did a needs assessment, a formal needs assessment, where we used audience response questions for everyone from administrators to frontline clinicians. And then we had our outcome measures. As I mentioned, we had to figure out how we were going to categorize these LSTs. So we broke them down into resource issues, such as a missing defibrillator. Maybe it was too far away. Maybe it didn't work. We had an anesthesia machine in our OR in the children's hospital that somehow got through testing and didn't work. We had to look at facility issues because it was a new hospital design. In the new NICU, it was a complete transformation of how our nurses were going to work and take care of patients with private rooms and how they were going to communicate in a crisis. We looked at system issues, processes of care that were changing, and then, of course, we identified performance gaps of the clinicians. For example, one of our West Campus testing, one of our nurses that were now part of the code team that had never been part of a code team before didn't know how to do a push-pull bolus because that had never been in her scope of practice before. So again, the focus of these debriefings were not, why didn't she know that? No. We just identified that and said, okay, this is an important training need for this new environment because our nurses have new roles. And we did this in 2 parts, a virtual NICU in the Pavilion for Women and a Worst Day in the Life, both in the West Campus and for our OB. But I'm going to focus for the rest of this talk about the Women's Hospital. So another hard part about this was how do you test these environments in a short amount of time? Your operational leaders, your architects, all the building folks, the construction folks, they don't like to let you in until the last minute. And yet we wanted to do this testing before we actually took care of patients. So we had to condense the testing and prioritize and do something that was a little different for me. We decided to run a virtual unit with 11 simultaneous cases running at once, 3 high fidelity and 8 low fidelity. Each nurse had their assignment of patients. They had their assignments of tasks to be done in the low fidelity, and then the high fidelity had some background on their patients that they were about to get. For our obstetrical testing areas, we decided a different measure. We decided a virtual unit wasn't going to work because, I wasn't as worried about how the whole system functioned. It wasn't transitioning from an open bay to a single, private patient. But I was worried about what's going to happen to a high-risk patient obstetrical emergency in each patient location. So what we did is we decided to do stop-and-go debriefings of 1 patient in a day. So this was the worst day in the life. Our poor pregnant mom, for example, started out in labor and delivery in labor and had a shoulder dystocia. And then we stopped and debriefed after the baby and mom were resuscitated. Mommy went to mother-baby unit. Oh, yeah, you guessed it. She had a postpartum hemorrhage. and we initiated our mass transfusion protocol. Then we stopped and debriefed. Then she had to go to the OR for a hysterectomy, and then we stopped and debriefed. After her surgery, she went to the critical ICU, where, of course, you guessed it, she went into cardiac arrest. So this was a long day for everybody involved, but it allowed us to have these stop-and-go debriefings, get some great data, and test multiple areas. I'm going to skip the video, but I will show you just a piece of how the day started, because we used both mannequins and standardized patients.
Good morning, how are you?
Good morning, how are you?
My name is Connie, I'm going to be your nurse today. Good.
That's
You are? Well, good, let me check your arm in real fast. Identify yourself for me. I know you feel a lot of pressure. We're going to get the doctor in here, Dr. Lunky, and check them just a minute.
Now they're delivering.
Now we're going to stop pushing yet. We're going to let you know, okay? You want knees all the way back. I want superhuman pressure. Who's giving it?
And I'm going to fast forward to a little bit of the neonatal resuscitation, which was a little crazy. We had new Volt phones, new ways of communicating. You hear all the noises going in the background. Everyone's distracted looking at this new phone, how to use it. We learned a lot. And we had observers in the background. You may see some people with different signs on them that are labeled observer versus the red signs that are the clinicians actually participating in the scenario. But they saved the baby, just so you know. All right. Oh, excuse me. So, what are some of the issues we found? We found a lot of different issues, and these are just some examples of those, but everything from resource issues such as inadequate staffing in our newborn center, resource issues such as surfactant not being readily available. It took 30 minutes to call it from pharmacy, which in the neonatal world is really not ideal. Other system issues such as communicating with each other. There was not great communication between the OB staff and the neo staff. Prior to this hospital, our neonatal team did still respond to the OB hospital next door, but we did all of our resuscitations outside of the room. So OB and neo weren't used to really talking to each other, and so we identified some great educational opportunities there. And one thing that we thought was really interesting is that we found in every single neonatal room, the computer order entry system that was put on a boom really close to the baby that during walkthroughs was identified by all the staff as being ideal because they could document, put in an order, and check their baby and document vital signs, was completely in the way in a crisis. As you imagine, a little baby doesn't have a lot of sides to get around them in a code, and that was obstructive. And so we actually moved them in every room, something that we wish we could have gotten in and done some testing pre-construction maybe to have prevented. But these are the things that are hard to identify just with walkthroughs and talking through, but simulation can help. Okay, so I'm going to argue that for many reasons, simulation is divine for patient safety. And you can kind of review those, again, the different facets that are important for conducting a good quality or patient safety initiative with simulation. Now I'd like to take out your papers again, do a little more homework, and I'd like you to think about maybe one thing you could do within the next year to improve your quality or patient safety in your institution using simulation, whether it's as a training for a training purpose or for an evaluation purpose of a system or a process or a new piece of equipment, anything that maybe your institution's about to go through a transition, or maybe you know there's an issue with some patient data, dashboard data that you're trying to move the mark on. Please write that down as a goal that you'd like to achieve with simulation, maybe with other things as well, but including simulation. Get those neurons synapsing. All right, everybody have a chance to write something down? We're going to move on to advocacy. So this is a little different. This is a little more fun, I think. I think of, my experience more recently with media, with the TV, which is definitely an unusual experience, but I've gotten an opportunity to learn more about media and the importance of advocating through that. And I think it's really important as healthcare simulation is growing out of adolescence and into adulthood that we really promote it, that we grow it, and that it becomes embedded into everyday practice. That it's not just an extra on top of things, but that healthcare systems embrace it enough to actually support it. And I think by raising awareness, whether that be through PR, legislation, or media opportunities, we have the really what I kind of think as the responsibility as simulation providers to make that happen and to try and move simulation where we want it to go. Additionally, I also think of advocacy as including those efforts that you might undertake in your simulation programs for the typical non-healthcare provider, maybe patients, patient-directed simulation, or in my case as a pediatric specialist, parents. And so just to give you a quick example, there's one thing that we've done in our program recently, which we're very excited about. We've started training our parents, not our providers necessarily, in high-risk patients, our neonatal patients that go home from the NICU with trachs and vents. We're basically asking our parents to become ICU docs and nurses. And when they go home, they do have the support of nursing staff that comes to help them, but a lot of times those staff may be only adult trained or very uncomfortable or unfamiliar with ventilators. And so really the parent has to become the primary caregiver for their child. And so this is a pretty high-risk situation. And we have some data to show that there is a mortality and morbidity risk associated with these kids that go home that are medically fragile. About 0.5 to 3% do die that go home with tracheostomies. And typically, the reason is accidental decannulation, so they lose their tube, or they actually block their tube, such as a mucus plug. And in our institution, we looked at some retrospective data. This is the work of one of our fellows, Dr. Hunalani, and myself and other folks, Melissa Cashin, one of our education specialists in our simulation center. And we found that 30% of our readmissions in the first week of life were actually related to these airway emergencies. So, our parents, they get great training when they go home. They practice how to suction the tube. They practice how to change it. They even spend 2 nights by themselves, quote unquote, before they go home. But they don't necessarily get to practice an emergency unless it happens on their kid before they go home. Not only if it happens on their kid, they're also supported by the doctors and nurses, right? I can't imagine just standing there watching one of our patients code and not stepping in for the parents and letting them manage it, right? I don't think that happens. So simulation, we felt, would be an opportunity to try and train our parents on these emergencies. And so what we've been doing is developing this course to hopefully improve the competency in care provided by the primary care providers or parents. We don't have any data yet, but I hope that this will sort of get your neurons synapsing and thinking about how can I make a difference in the community around me, whether that be patients or parents. So moving on to media. Media is a great thing in many, many ways. It's an opportunity to educate and advocate the benefits of simulation. We can increase support for simulation legislation and hopefully funding so that every institution, healthcare institution, has simulation opportunities. We can demonstrate the value and accomplishments of simulation both internally to get more buy-in in our own programs and externally for the greater good. Maybe attract donors, raise funds, even raise staff morale. And hopefully create new collaborations and connections with other institutions, both locally and far away. So, when we put our simulation center out there on some type of local news report, other centers may call us and say, hey, I didn't know you were doing this, I want to learn about that. Or vice versa, we see, the surgical simulation center down this block and what they're doing and say, hey, that's really amazing stuff you're doing, let's connect. So, how can you get more media coverage? It can be hard, but there are ways. And I think, it is possible to, deliver exciting, a little bit of drama, media that gets the media folks interested, but still not be sensational and still convey the message that you want. And you can do this through press kits and press releases, particularly if you're opening up a new program or a new center, brochures, websites, social media, have tours, TV interviews. Again, work with your hospital PR department as much as possible, your institutional PR department, to try and cultivate these opportunities. We have a great relationship with our PR department, and they're constantly asking me, what's new in the Sim Center that maybe we can, try and pitch to the local media. And then, ultimately, you want to advocate for simulation legislation so that we can support this. As we get more data to show the benefits, we can hopefully garner more support everywhere. And so I would advocate that advocating for healthcare simulation is divine. And this is a really important cause. And these are all the different ways that you can do that to increase awareness for healthcare simulation. So you guessed it, it's another connection chart. Get out that piece of paper and write down one thing that you can do within the next year. Again, I'm giving you guys a year timeline for all of these goals. So you're only supposed to have 2 or 3 learning objectives, so I apologize. If you want to skip one, it's really okay. Write down one thing you can do within the next year to increase awareness for healthcare simulation through an advocacy activity. So whether it's reaching out to maybe a non-healthcare provider like a parent or a patient need, or it's maybe try to garner some increased awareness in your local or broader community. All right, so I'm going to start to wrap up here. Research. I'm not going to go into details because you've had a lot of connections with Dr. Hunt's presentation on research, but it is very important. There's so many questions that we yet to have answered. How best to utilize simulation, how best to evaluate the impact of simulation, what kind of, simulation, for what purpose should we use it for, how much, what's the dose, what's the retention. All of those things are opportunities that many people are already looking at, and we have still much more work to do. Your focus of simulation could be as a therapeutic intervention. I'm going to use simulation to try and improve X. It could be used as a diagnostic tool, such as our simulation-based testing of clinical environments. It could be also used, you could use research to evaluate the best practice of simulation. What's the best way to learn this? Is it rapid cycle debriefing, as Dr. Hunt showed us, or is it traditional debriefing? May depend on what it is you're trying to teach. And so, really, we need to connect the need also with the technology that's out there. So in our center, as a pediatric hospital, we constantly think of things that we don't really have a mannequin for, and I'm sure many of you out there have found those situations. And so we've been working on some projects and connecting with people outside of healthcare to help us make mannequins or modify mannequins that meet the needs of our training. So what you see in the picture there is a project we're working on, the big child mannequin, with Rice Biomedical Engineering students, where we've been modifying a mannequin that was donated to us to try and improve physical diagnosis, hepatosplenomegaly of a child, so that we don't have to do that 10 times every month on a real child that's got a tender liver. And then additionally, we've modified our tracheostomy mannequin for the course that I explained before to train parents, and that was actually through a connection through Bristol Children's Hospital. So we have a lot to thank them because they went ahead and figured this out, and then we were able to use it in our program. So connections is what it's all about, and research in healthcare is divine for all of those reasons. The many, many, many important things when it comes to research, particularly looking at those T2 and T3 outcomes. So now I'd like to ask you, no surprise, to write down one research question you think would be important to answer related to healthcare simulation. I'm not saying you have to answer it. You just have to think of one good question. What's something that's been burning inside you? Oopsie, I don't know how that happened. I hit the wrong, whoa. Uh-oh. I was just at the end too. That's no good. Here we go. I knew I couldn't escape the whole talk without one technology issue. Where am I? Oh, that's way up there. Forgive me. Nope. I can't blame it on the chemo brain if it's the computer, right? It's the... Okay. I think we're here. Okay, competency assessment, last arm. I'm actually not going to even go into this in detail, but many of your efforts in healthcare simulation may be related to competency and assessment, and this is an important facet of healthcare simulation. There's still much work to do in this, but it's important as educators, as simulationists, to try and determine what it takes for a clinician to be competent or professional and how best to evaluate that. And oftentimes this may have the requirement of validated scenarios, assessment tools, and this is an opportunity for a lot of research as well, particularly when you're looking at healthcare teams. There's a lot of great tools out there, use them, but there's a lot of people trying to make new tools that work for their institution. So competency assessment has really an opportunity to make a difference because it allows us to really look at what are the competency levels of our providers and helps, my goal would be for standardized practice. Because if we all have a certain level of competency and if we can train to that and then, assess that with simulation-based activities, it's really an opportunity to make sure that we're delivering good healthcare and doing a better job at taking care of patients. And I'm just gonna, for time's sake, go quickly through this, but of course, competency assessment. You heard a lot about this on our talk on Monday, and you know that it's a great opportunity for healthcare simulation to assess competency assessment because it's much more realistic to what we do every day, right? Multiple choice exam may not necessarily be the best outcome measure. Maybe it's how we do in a simulated environment. So think about one competency assessment goal for your program, your simulation program, that you would like to achieve over the next year. Maybe not. Maybe it's already in a competency assessment program that's out there, a tool you'd like to incorporate that you just haven't been able to start up with. You don't have to make your own. All right. Now for the fun. Are your neurons synapsing yet? Have you thought about all the different ways you can use healthcare simulation to improve patient care outcomes? Right? Either research, competency assessment, patient safety, education, or even advocacy, okay? So I think all of these things are important for improving the way our patients care for. If you're not synapsing, I'm so sorry, I'm blaming the chemo brain. I haven't done a good job, but hopefully, maybe not everyone out there has scrambled eggs in their brain. Maybe you do, because it's been a great week. Maybe you put some things together, I'm hoping, even if it's just one. So, last task. Now is the time. I would like each of you to connect the dots and make connections with that person you met before. What I want you to do before you get up, write, if you're willing, your email or phone number on your piece of paper. And I want you to give your list of goals to the person you connected with earlier in the session. And I'd like you guys to exchange these. And then over the next year, follow up, mentor, support, guide, advise each other, and report back, because we're going to have an opportunity to report back in the society. All right, take 1 minute. Give your pieces of paper to each other. Have fun with it. No pressure. I won't know if you didn't do it. All right, has everyone made the exchange? Everyone made the exchange? Okay. So now each of you, your task is to follow up at least once, if not many times, with your partner in crime, so to speak, to see how they're doing on achieving their goals. But not only to follow up to make sure they're doing it, but to help them. See if there's a way that you can help or connect. Is there some area of expertise that you have that you could share with that other person, or make another connection to someone who does? So I hope that you will each connect with each other and making your simulation goals a reality for next year. And I'm hoping that if any of you do have success, which I know you will, in any one goal, that you'll share it on the listserv. So I've talked to Dr. Frampus, and he says, well, you can have an opportunity to share your story of success. Because by sharing that success, you're going to make a connection with other folks who maybe thought, oh, I can't do that, I don't know how to do that. You may have been dealing with the same challenge that they're dealing with, and raise awareness to help them achieve their goal. So I really want to thank everyone for your time and your attention, and hopefully your commitment to simulation, and most importantly, your enthusiasm today. This is something I'm very passionate about, and something that all of our sim team is passionate about. This is a quote from one of our esteemed educators in our simulation center that we hold true. Every error made and studied in simulation is ideally an error prevented in the real world. And this is why we're all here, to make a difference. And so I have many people to thank, my simulation center team, who is amazing, and all of our faculty, many of which are here today that are presenting, who make the simulation program what it is. And I think we all just need to go forth and simulate. So, thank you. Do I hop down? Do I hop down? Is it okay? Thank you. Thank you. I hope that was okay.
Okay, thank you, Dr. Arnold. That presentation really helps us make